Marcia.
So, Governor, I have a kind of a complex question. About a couple of weeks ago, you said that as testing numbers went up, you might have to turn the valve a little bit to reduce some functions like indoor dining, gyms, salons, and in New York City especially, the numbers are going up almost every place except Manhattan. So is it time to turn the valve a little bit more in terms of indoor dining, gyms, beauty salons, and are you thinking of any more orange zones in New York City itself?
Here's the problem with the new numbers. The valve no longer controls the spread. When we started, the spread was indoor dining, large social gatherings. The spread now, over 65%, small, at-home gatherings, living room gatherings. And it's frightening, but it's interesting. People adapt. Okay, you can't go to a bar. You can't go to a restaurant. What do? You start to go to people's homes and watch the football game, or come over and we'll play cards, or come over and we'll listen to music. We are social beings. And when you close down social venues, it's not that we're going to stop socializing. We'll just find a different place to socialize. So it's coming from these home gatherings. That's why all these states are doing these 10 limits. Kentucky went to an 8 limit. The problem with these are, how does government really enforce that, right? It's sort of like mask wearing. The only thing you can do is educate people and hope that they hear you when they wear a mask. I think we only gave out, a handful of tickets on mask wearing. It's not government enforcement. It's public education. Family gatherings, we didn't do any tickets over Thanksgiving for people who had more people in their house than 10 people. This is not going to be a government enforcement thing. You can't control it with a valve. Either people are going to hear it and get it, or they're not. Or they're not. Either they're going to see those numbers going up and they're going to get it, or they're not. I believe they will, because I believe in them. But this is not something government can really address with enforcement. That's why I wanted to take on purposefully the counter argument, right? Which we hear about the gatherings and the 10. Oh, this is just politics. Can't be politics. Democrats and Republicans agree. It's the only thing they agree on, Trump and Biden, is this one piece. And the state rule is more lax than the CDC's rule. Well, I think it's tough to show that you defy government rule. And I'm going to post on the website, I defied government rule. Oh, really? You think that's tough? No, what's tough is working in an emergency room, working in a field hospital, working with people who have COVID. That shows guts and character, in my opinion. And what shows character is not creating a case for a nurse or a doctor or an ambulance driver to have to deal with. But that's what it's going to be now. It's about people accepting it and hearing it.
In your presentation, you reserved the right to do another New York pause, which in a sense is another lockdown. So are you now giving up on closing indoor dining and salons and gyms and saying, if the numbers go up, the only solution is a lockdown?
No. Before you get to hitting the pause button and closing everything, you can have additional restrictions. And an orange zone does that, et cetera. But those numbers are relatively small compared to the small gathering spread. That's where it is coming from. Once you get past that, you're talking about a few percentage points here and a few percentage points there.
So you've given up on restaurants and gyms and
No.
salons?
The a orange zone has additional restrictions on restaurants. A red zone has additional restrictions on the restaurants and the gyms, etc. You know, we still have the yellow, orange, red.
Are you going to declare more orange and red zones in New York City because the numbers are so high?
Well, as the numbers go up, I want to add to those numbers the hospitalization rate, because the most critical communities are going to be those where the hospital is overwhelmed, right? And that's what we want to focus on. Remember, Ken Rasky mentioned Italy. Remember what we went through like in Elmhurst Hospital, right? Where the hospital was overwhelmed because that community overwhelmed that hospital. That's all that happened there. It gets into my, well, why didn't you distribute patient load across your system? We learned that lesson. But Elmhurst was overwhelmed from that community. The numbers at that time that Elmhurst happened are not that different than the numbers today. How striking is that? Do you have those numbers?
So March 23rd was that week in early March. There was 3,500 people with COVID hospitalized statewide on March 23rd, which is the same number that we have today.
Do you get that? The day Elmhurst overflowed, let's call it, collapsed, the same number of COVID people were in the hospital system as today. 3,500 on both days. But Elmhurst collapsed. How did that happen? That community had a rate that was growing that you did not notice, that then went into one hospital. That hospital did not distribute across the system and was overwhelmed. That's what we're adding to the yellow and the orange and the red.
But regarding load balancing, I mean, how much do you have a situation where it's happening so quickly, patients are so sick, you can't necessarily move them? I mean, you're talking about, an analogy where this is a war. The general will say the minute the shots are fired, the plan goes out the window. It gets very hard to kind of transfer patients who might be at a point where they can't be transferred.
Zach, I've had this discussion at length. Yeah, I hear your point. This is the argument we had every day in the spring with these hospital administrators until 2 o'clock in the morning. You have 10 hospitals. You knew the rates were going up in certain areas among those 10. Now, you want to say you only had 1 week notice? 6 days notice? 5 days notice? You knew the rate was going up. And rather than letting them walk in the door in that hospital, when Zach came to the door, why didn't you say, Zach, I'm going to put you in a van and take you 3 blocks away to my other hospital that has capacity? Well, that's not the way we normally do it. That bureaucratic mindset, whether it's in government or large hospital systems, that's not how we operate. And that's when we came up with Surgeon Flex, which is throw the book out on how you operate. I don't really care how you operate anymore. So what we're saying today is among those systems, because they understand exactly what I'm talking about, because we had this discussion. In the spring, everybody said, oh, well, nobody told us. Balance among your 10 hospitals today. Today. You have 10 hospitals? They should all be at the same capacity. You know what hospital has the highest rate of COVID patients? Because you went through it in the spring. Make sure that hospital and the ones surrounding it have reduced bed count now so you have capacity. Balance that load among the 10. Wherever there's a hospital system. Surgeon Flex is the next level, where the state comes in and says to you, you have 10 hospitals. Your 10 hospitals, I need you, you're in the Bronx, I need you to take people from Buffalo because Buffalo's overwhelmed. And I'm going to bring down 100 people from Buffalo. That's statewide surge and flex, where you shift among systems, which was a wholly inconceivable concept. You know, I'm going to take Northwell people and send them to Mount Sinai. That's surge and flex. Northwell, you're going to send nurses to Mount Sinai. Northwell, you have to send PPE masks to Mount Sinai. That's statewide surge and flex, which was just an incredible level that was inconceivable. All we're saying today is we're enacting that within your network, you must balance the load. And you went through the spring, Zach, so you know the numbers. It's going to be the same communities. And you've been watching the numbers go up. Well, we operate each hospital as if it's its own thing. Yeah, not in a crisis. You don't.
When it comes to using
Hold on a second, Peter. Go ahead.
when it comes to using hospital metrics, what are the specific thresholds and data points that a region now needs to hit to enter one of the colored zones, and how do you reconcile that with positivity rates? Are we totally ignoring
No,
positivity rates?
it's going to
now?
be in addition to the positivity rate. Those numbers we're going to set this week. We're awaiting the Thanksgiving results. And we're doing it with hospital administrators. In other words, I don't believe the Thanksgiving wave has hit yet. You need 7 to 10 days. So I don't believe we've seen the hit from Thanksgiving. Now, is that going to be harder in New York City or Long Island or parts of Erie? I don't know. But during this week, we'll see the Thanksgiving impact, and we'll be taking an inventory of each hospital to find out exactly where they are in terms of availability. Because capacity is how many beds do you have available today? How many beds could you make available if you load balance with your other hospitals? How many beds could you have if you canceled elective surgery? How many beds would you have if we mandated you add 50%? Add all that together, and now that's your capacity. And we need to see the results from Thanksgiving, because I think they're going to be dramatic.
So do you expect fewer or more orange zones in the state, given this new layer of using hospitalization numbers as part of this strategy? Like if we were depending solely on positivity rates before, and the numbers were increasing, there were more shutdowns on the horizon. But now with hospital metrics being involved, do you expect fewer or more colored zones?
They'll be different because they'll be also adding the hospitalization capacity. Our positivity rates are going to be surpassed in a matter of time. They were all best case scenario and artificially low. 3%. Just think of the number 3%. There's no state in the nation that's at 3% anymore. It's only Vermont and Maine. At one point, you have to understand recognize the reality that the cases are going to go up. I want to make sure our number one priority is hospital capacity. That has always been my nightmare. Has been Italy, Elmhurst, hospital capacity. So that is going to be added in terms of our prioritization. I'm sorry.
Yeah, you talked about hospitals reaching out to retired doctors and nurses, which happened in the spring. In the spring, you had medical personnel from across the country coming in. That seemingly can't happen now. How concerned are you about having enough staffing as we get into post-Christmas, post-New Year's?
That's a great question, and you're right. I'm more concerned about the staff shortage than I am the beds. The beds we can build. It's extraordinarily difficult and expensive, but we can build beds. We can't create more staff. And the staff is starting tired. And you're right. We had, how many came in nationwide, volunteers?
More than 90,000.
90,000? We had 90,000, but how many were national versus New
It
York?
was about 60,000 outside of New York.
60,000 outside of New York. How beautiful, the American spirit. 60,000 outside of New York. They're all busy. In the spring, it was just us, right? Nobody else had the problem. They're now busy in their own community. So that's not going to happen to anywhere near the same extent. So it's going to be more just our retired and nurses. And I am very worried about staff shortage.
So it sounds like the makings, potential makings of a crisis. How do you manage that?
You manage it by raising the pool overall of staff as large as you can, balancing the load across the state, and then doing everything you can to reduce the spread. The good news is we know what we're dealing with this time in a way we did not know in the spring. And we're better prepared, and we're going to be smarter in the management of it. If you can keep the system balanced and you don't overwhelm any one place, and you don't have people working around the clock day after day after day, that's one situation. But look, crisis, potential crisis. Everything is a potential crisis unless it's managed properly, right? I think we're going to be fine here on all of this, but we have our work cut out for us. I mean, you can't just sit by and let this happen. It is a function of action, and that's been the difference between the New York strategy and the national strategy from day one, right? National strategy was, well, let it happen, and whatever it is, and I don't think it's that bad. Denial. We were the exact opposite. We were activists, truth tellers, informers, and managers. And that's what we're going to do again. I'm telling people, the way I told them the truth in the spring, I'm telling them the truth now. Those small gatherings at home, dangerous, creating a real problem. God's honest truth. No political hype, no BS. We're going to have a problem in the hospitals. I'm telling you that right now. It's going to be a serious situation. We're going to manage it. We have to work together. Hospitals are going to have to do things that they don't normally do. I'm telling you that right now. But it is a manageable situation. And I'm telling you the vaccine will end the war, but the vaccine will not be ready for distribution in the time frame you think it is. So you have to recalibrate your clock if you are thinking, I can be irresponsible now because next week I'm going to take a vaccine and everything's going to be fine. It's not going to be next week. That is the God's honest truth as I know it. And what worked in the spring, and the reason you're wearing a mask today, is because we told the truth and New Yorkers responded. There was no government enforcement of anything that made a difference. Little bit, bars and restaurants. And I believe the same thing here. I'm going to tell New Yorkers the truth. I'm going to do what I have to do on my end. But I believe they'll respond.
Governor, how does contact tracing?
Hold a second. Mr. Chancellor Malatras had his numbers wrong. So let's relish this moment for a second. That Chancellor, so you want to say, Mr. Chancellor,
It's
you were
flipped.
wrong?
I was wrong.
Oh, who appointed you Chancellor?
It's 30,000 were out of state, 60,000 were within state. We had 90,000 total. It ended up being closer to 100,000.
I knew he was wrong.
Out 30,000, a little more within.
I knew he was wrong, but I was going to hold it in my pocket and use it at the right time. Anybody want to add anything thus far?
No, just echo that Jim was wrong.
Yes. Dr. Zucker?
I'll just say two things. One is that we understand this disease a lot better than we did the first time around, and also on the balancing of the system. It's not just COVID patients, it's also the non-COVID patients that they can move. So balancing involves all the other medical conditions, surgical conditions as well.
Governor, there's been a lot of reporting that contact tracers are struggling to keep up with all the new cases across the state, especially here in New York City. How confident are you that the state really has the data to know where the coronavirus is spreading the most?
We have more data than any state in the United States of America. That you know. Is that enough? It's more than anybody else has. You have now done tests on, we've almost done as many tests as we have people in the state of New York. Is that amazing? We've almost done as many tests as we have people in the state of New York. Contact tracing is not perfect. You are right, Zach. They don't get a great response rate, and it depends on whose contact tracers, and different systems are better and different systems are worse. But we have more data than anyone else. And at one point it becomes redundant, right? You're only testing data on 4 sources. So
If New York City can identify where 4 out of 5 cases are coming from, I mean, that seems like that would have a pretty big impact on knowing where the virus is actually spreading and acting accordingly, no?
yeah, but there's also what a statistician will tell you is you can take a poll of 500 people and extrapolate what people across the state think. New York City only gets the results of 1 out of 5. Yeah, but 1 out of 5 turn out to be 100,000 sample. If you know where 100,000 people got the virus, that's a hell of a base. Who didn't ask you a question?
Are you predicting that at the end of when you finally get the results in from the post-Thanksgiving period, 7 to 10 days from now, that you'll be making more red, orange, and yellow zones around the state?
Yeah.
In New York City and the suburbs?
I already did my predictions. See, I want to maintain the position on operating on facts. I gave you the predictions. I'll make you a bet on the Buffalo Bills if you want. But beyond that, all I want to say on predictions is you'll see a continued increase is my bet through mid-January. I don't even know if the commissioner's with me on that bet. What would you say?
I'm good with you on that.
Yeah, would you?
Yeah, maybe a
The
little.
question is, in 10 days, do you expect to name more red, orange, and yellow zones?
My belief on my crystal ball is the Thanksgiving number is going to be big and it hasn't come in yet. If that's the case, yes, but we have to see what the numbers are. Let's do someone who hasn't asked, please.
Thank you. About this keeping the schools open, Mayor de Blasio has offered a plan to have weekly testing for students. So if those students are in an area that turns into an orange zone, are they then going to have to close the school for 4 days the way the state has and then reopen again, or can they stay open?
Who wants to answer that?
They can stay open. That's something that we worked through in this more nuanced approach, recognizing that, as you said, the mayor's doing testing on a rolling basis, so it's not like if there was no testing and you would have to close and assess, so they would be able to stay open uninterrupted.
Let's take one more.
Yes,
Lady.
Governor, I had a question for you. Noreen Chaudhary from Pix 11. We can't see each other because of the masks. I had a question in regards to Queens hospitals. You mentioned Elmhurst. These were the hospitals that were most overwhelmed at the peak of the pandemic. We spoke to a number of them last week, and they talked about so many of those hard lessons that were learned. In terms of the keeping up with the supply of PPE and additional medical equipment and such, where's the oversight to make sure that those hospitals that were really inundated last time don't have the proper supply that they do versus all the other ones?
You want to answer that, Dr. Zucker?
Sure. We monitor this on a daily basis to make sure they have enough PPE. They're supposed to have 90 days worth of PPE. We're tracking that. We are in contact with all the hospital administrators on a regular basis as well, and also on all the numbers about how many patients are in the hospital, how many COVID patients in the hospital, what we've seen in the ER. And on a regular basis, I reach out to the hospital administrations to be sure that we know exactly what their problems are ahead of time.
But let me give you, for instance, what happened on lessons learned. The PPE, these masks, hospitals, they're actually bulky because they use tens of thousands of these. They were so available, hospitals just didn't really stockpile them because you could get them delivered the next day from any number of vendors. It was inconceivable that these would become on short supply. A mask, by the way, N95, that we were paying 70 cents for pre-pandemic, we were paying $7 for towards the end. Just think about that. We have since mandated that a hospital has to have a 90-day supply of these and everything else at the rate of the height of the pandemic. Okay? So take your high caseload during the pandemic. You have to have a 90-day supply of PPE by department regulation. I'll bet you most of them didn't have a week, but there was no reason to. You know, it'd be like saying to you, you have to have at least 10 cartons of eggs in your refrigerator. You know, I don't have 10 cartons. I have one carton at a time, then I go and I buy another carton.
Have you found that those supplies have been adequate across the board since you started checking and implementing that mandate?
The Department of Health, literally, that's what the commissioner said. It's a requirement. They test it, they call, they report it. So yes, but that's something we learned. Now the problem is you have 10 cartons of eggs in your refrigerator. So now you have no orange juice, but one problem at a time. Last question.
Clarification of the numbers. 30,000 out of state, 60,000 in state. Were those people on a list, or were those people who actually came and helped?
We had about 40,000 that were used in some capacity for nursing homes and hospitals of the 90,000 off the list. And we maintained a central database at the state where we helped with the background checks and everything else so they could easily go right into the facility.
We will confirm the chancellor's numbers. If they are incorrect, we will correct them publicly. Thank you, guys. Good to see you. I'll see you. Yeah.
As a whole, in terms of
No, neighborhood by neighborhood, because the neighborhood by neighborhood, because even when you deal with hospitals, it goes community by community, right? Think of Elmhurst. That was community driven. Thank you, guys.